Well, congratulations on staying awake. And if you fall asleep now, we all know it's my fault. So I have the honor of discussing sliding hip screw, which I think really is a lost art. And so I want you guys all to face your fears with me, and let's move forward and see if I can convert some of you guys to join the dark side. All right, so these are my disclosures. We'll go through a little bit of the agenda, a little bit of the history of sliding hip screws, then some trends, its indications, some of my little tips and tricks that I use when I do these cases, some of what I think are the perceived benefits, and I have a couple of cases that we'll talk about. So in the early days, somebody has a hip fracture. Back in the days of Hippocrates, you got hung upside down, put in traction, and you probably laid there until you died. Then they invented some plates and screws. We started using those. And as the technology started to develop, we developed newer systems. So the first kind of real important system that came out was these impaction systems, the blade plate, which is on the lower right, and the nail plate, the Jewett nail, on the lower left. These are great fixed angle devices, but don't really allow for very much compression. Then they came up with these ingenious ideas that allow for telescoping mechanisms for sliding and compression. So the sliding hip screw came about, and ultimately the cephalomedullary nail, which we're all very familiar with. So the first sliding hip screw was actually designed by Robert Denis in 1934, but was actually never used clinically. The first clinically used sliding hip screw was designed in 1951 by Ernst Paul in consultation with Gerhard Kunscher. And it was basically this little device on the bottom left, two-hole side plate with a telescoping screw that eventually turned into what we kind of know today as the modern sliding hip screw. It had really great results and became really popular through the 1980s and ultimately became the gold standard. However, in 1988, the first cephalomedullary nail was introduced, and all of a sudden the trend started to change from using sliding hip screw as the gold standard and increasing levels of use of this cephalomedullary nail, especially in geriatric hip fractures. Englund described this trend in JBJS 2008. We went from 3% in 1999 use of cephalomedullary nails all the way up to 67% in 2006. Another article showed that cephalomedullary nails were primarily used in 68% of surgeons versus 19% of surgeons use sliding hip screws. And the reason that they use them was stated as the ease of use of the cephalomedullary nail. My own personal thoughts. Number one, I think the indications for sliding hip screws may be a bit challenging, and some of the fractures we see may not be suitable for sliding hip screw. That being said, you have to think about the indications. So sliding hip screw requires knowledge of the appropriate indications, which makes decision-making more difficult. A cephalomedullary nail in general tends to be an implant that fits all the fractures. Sliding hip screw is an implant that fits some fractures. So the indications for using a sliding hip screw in general are intracapsular femoral neck fractures, basicervical femoral neck fractures, and stable intertroches. So your 31A1s, top row, are your stable intertroches. A2s and A3s tend to be more your unstable intertroches and likely more suited for your cephalomedullary nails. So when we define a stable intertroche, what do we mean? We're talking about an intact calcar, which is a posterior medial cortex extending approximately 1 centimeter distal to the lesser trochanter. We also discussed the lateral wall, the integrity of the lateral wall, which we'll get into in a few seconds, and the fracture plane being perpendicular to the screw trajectory. So a normal obliquity versus the reverse obliquity. So lateral wall thickness is a common discussion point about stability. And there have been a lot of different ways that you can kind of figure this out, but one technique to actually be able to quantify whether you have an adequate lateral wall thickness would be to measure from the vastus ridge distally about 3 centimeters and a line that follows your 135-degree screw. If the lateral wall is thicker than approximately 20.5 millimeters, that's stable. If it's less than that, then it's predictive of a possible lateral wall fracture. There's also been CT scan studies that have been looking at different ways to quantify this and maybe have a better chance of being more accurate with the thickness of the wall and its propensity to fracture. But I'm not sure that CT scans are really that useful on an everyday basis for all intertroches for that reason. What about, why in unstable intertroches are we saying that sliding hip screw may not be the best idea? So there have been several studies, but this biomechanical study looked at an integrated 2-screw cephalomedullary nail device versus a sliding hip screw, and it showed essentially that there's a strong biomechanical advantage for cephalomedullary nails in most intertroches. Unstable intertroche fractures did better with a cephalomedullary nail biomechanically than a sliding hip screw. They can be used, cephalomedullary nails can be used in all patterns. This is due to the fact that the lateral buttress is moved more medially. There's less shaft medialization in unstable patterns. But does this really necessarily lead to a functional improvement? So there's been a multi-centered randomized controlled trial comparing the similar device to sliding hip screw, and looking at where the sliding hip screw fits in. Essentially, an unstable intertroche is, for the most part, a contraindication to the use of the sliding hip screw. It often will lead to significantly more shortening than your cephalomedullary nail. But functional outcomes, depending on what test you're looking at, may be similar. So your time up and go test was similar. But if you had greater than 2 centimeters of shortening, then your gait speed was significantly decreased. So depending on what you're looking at. So that's basically the indications. So some tips and tricks. So one way to assess the lateral wall width and the stability of the fracture is to get a traction internal rotation view. It's been shown to improve accuracy of classifying the fractures. It gives info on whether the fracture can be reduced on the fracture table, and may help impact your management and implant choice. So I typically get these on all my intertroches. And oftentimes I'm doing these cases either on a fracture table or on a radiolucent table. And this can be done supine or in a lateral position. You typically will do a lateral approach for the sliding hip screw, starting at the vastus ridge, extending distally about 6 to 8 centimeters. This is the 135-degree guide that most often is used. It has 4 little prongs on it. What's important to see about this is having all 4 prongs flat on directly on the femur in line with each other. You want to avoid the popping a wheelie, which is what the top right picture shows, where the front 2 tines lift off the lateral cortex, thereby changing the angle of your device. When you're measuring the depth of your wire, take off about 5 to 10 millimeters, as the guide is not measuring the actual threads. Next, you're going to be using the triple reamer. It's very important to engage all 3 parts of the triple reamer. You have your first part, which corresponds with the shaft of the screw. You have your second part, which corresponds with the side plate's barrel, and the third part corresponds with the angle where the side plate meets the barrel. So you can see in this picture on the top right, that beveling of the bone is the engagement of that third part. You have to do that so that your plate can sit flat. In young patients, I tend to use a tap when using the sliding hip screw, and I'll consider using a derotational screw as well. As you're putting it in, the head can rotate, and having a screw in there can help prevent that. One little tip is don't remove the insertion handle until you have your plate centered. In the top right, you can see the plate. We put it on, it's rotated off the femur. If you start putting a screw in, you're going to miss the femur or go unicortical, which can lead to a potential stress riser and fracture. So I like to always get a lateral and then use the handle to then derotate the plate and make it parallel with the femur, so you can then put your 2 screws in. Next, you want to make sure that your screw, when it's in, has an appropriate tip apex distance. This is the classic article by Baumgartner showing that tip apex distance less than 25 decreases your risk for cutout and varus collapse. If you have to be in any position, you want to be center, but posterior inferior is okay. Anterior superior is your worst position, so you want to try to avoid that if you can. Then the question of how many holes do you want to use? 2 holes are adequate. There's been several studies out there. This one by Bohlhoffner et al. Show that there's no difference between rate of cutout for 2 holes versus 3 and 4 hole side plates. No increased loss of fixation. There's been a shorter surgical time and less blood loss. Occasionally, you may run into some trouble, but there's several bailout options. So one option that's available is what's called the trochanteric stabilization plate, something that can be very useful. If the lateral wall integrity is of concern, the trochanteric stabilization plate can act as a buttress to prevent shaft medialization and stabilizes the lateral wall. It can also be used as a way to fix greater troch fractures. However, when you're using that plate, you want to have a 4-hole side plate instead of your 2-hole side plate, as you need all 4 holes to engage the TSP. The TSP does have some locking screws, so you can get fixation into the greater troch fragment as well. And there have been several studies showing its benefit in certain fracture patterns. So what's the benefit? So we said that cephalomedullary nails tend to be better used for unstable fractures, can be more biomechanically stable. But why am I advocating for sliding hip screw? Well, number one, it avoids the abductors. When you're going through the abductors, you're putting a 15 to 17 millimeter hole through the muscle, which significantly weakens the gluteus medius and can lead to worse gait and balance. It's a fixed angle device, so it can do well in high shear environments. And lastly, it's much cheaper than your cephalomedullary nails, about 20 to 40%. So in a head-to-head comparison, we're looking at stable inner trochs. There's really not a huge difference. You can look at the literature, you can cherry pick your data, but in general, you could probably find something that would benefit one or the other. In terms of blood loss, there's no big difference. In terms of transfusion rates, you can find a study that shows cephalomedullary nails have more or sliding hip screw has more. So I call that a tie. Operative time is a tie. Intra-op versus post-op complications, a tie. Functional outcomes, maybe there's a slight edge to cephalomedullary nails, especially if the fracture is more unstable. Mortality rate, there's no difference, but cost, significant difference, about $1,900 per case. So sliding hip screw is a much cheaper implant. The average cost per patient with a sliding hip screw is about $17,000 versus for a short cephalomedullary nail, $19,000 versus for a long cephalomedullary nail, $21,000. So a sliding hip screw is about $4,000 cheaper than your long nail. So in terms of cost savings, I mean that's obviously a big thing that's going on in many of the hospital systems these days. This is a way to do it. So you have an implant that, when chosen appropriately, is equivocal to the much more expensive implant and may have some functional benefits in terms of your abductor function. So here's a case, stable inner troch, fixed with a sliding hip screw, did well, no issues. So we know that there's the stable inner troch is a good use for the sliding hip screw. But are there any exceptions to the rule? Is the sliding hip screw potentially a good bailout for an unstable fracture? Well, there are certain high energy proximal femur fractures where you have a displaced greater troch. And as you know, when you're doing a cephalomedullary nail, you're going right through the greater troch in many of the cases. So if you have a young patient and a displaced greater troch fracture, maybe putting a nail through that, displacing it more, preventing it from healing, leading to a non-union, can lead to worse pain and abductor weakness, is maybe not the best idea. Maybe using something that avoids that would be beneficial. So that's where I think the sliding hip screw and a troch stabilization plate may be a good option. So here's a case, 40-year-old male, status post ATV rollover. So he has this proximal femur fracture with some subtroch extension with this big greater troch fracture fragment. I thought that would probably be a bad choice for a nail, as you're going to go right to that start point. You're never going to reduce that troch fragment, and it's probably going to go into a non-union. So we fixed it with a long sliding hip screw and a troch stabilization plate and some derotational screws. So in summary, sliding hip screw is a good implant for stable inner trochs. It has similar outcomes to cephalomedullary nails in that setting. It does have less abductor injury and post-op weakness. It has significant cost-saving benefits. It requires the appropriate indication. So knowing the indications is important. But it can be used in a setting where cephalomedullary nails may not be appropriate. So hopefully this takes away some of that allure of the sliding hip screw, and maybe some of you guys use it a little more. Thank you.